Hello, everyone. I'm Dr. Raven Baxter. I'm your host of this episode of the Raise the Line podcast. I'm a molecular biologist and director of science communication at the Cohen Center for Recovery from Complex Chronic Illness at the Icahn School of Medicine at Mount Sinai Hospital. And at the center, we work to advance treatment and knowledge of long COVID, tick-borne and vector-borne illness, myalgic encephalomyelitis, and chronic fatigue syndrome, and connective tissue disorders like hypermobile Ehlers-Danlos syndrome. Post-acute infection syndromes are characterized by persistent symptoms that last for months or even years after the initial infection has been treated. And many of these conditions are often misdiagnosed, leading to delayed treatment and prolonged suffering for these patients. And so we are making some progress on understanding post-acute infection syndromes and their root causes and their drivers. But there is not currently a standardized protocol for treating post-acute infection syndromes. And so we are excited to speak with Dr. Ricia Pretorius, who is a distinguished professor and head of the Department of Physiological Sciences at Stellenbosch University. Her research deals with coagulation in a variety of medical conditions, including diabetes, chronic fatigue syndrome, Alzheimer's, Parkinson's, COVID-19, and long COVID. Dr. Ricia Pretorius is highly regarded in her field by practitioners and patients alike. And so I'm really excited to dive into this conversation and bring knowledge to our medical student audience. So thank you, Dr. Pretorius, for having accepted our invitation to speak today. I'm really thrilled to speak with you. I've heard many great things about you even prior to coming to Mount Sinai. So I know this will be a wonderful conversation. So I think that your work is very interesting because it sort of sits at this nexus, which is kind of a point where patients are seeking care, but there may or may not be testing available to sort of address this issue. So I am a long COVID patient myself, and I was aware of your work regarding microclotting and its role in disease. However, when I would bring this knowledge and information to my provider, they'd say, well, we ran your D-dimer test and we didn't find any clots. So I think, being that our audience is medical students, yes, I would love to get a foundational scope of your work and its role in post-acute infection syndromes.
Thank you, Raven. It is a pleasure to talk to you and to your audience. And perhaps with that in mind, and just putting the D-dimer question just a little bit aside so that we can start from the basis of what is clotting. And I'm sure your students that are listening to this podcast and video recording would obviously be very familiar with clotting and the clotting cascade. But just to have a quick background on what happens in a healthy individual and how clotting progresses. So if you are a healthy individual and you cut yourself, we know that collagen is exposed on the place where you have cut yourself. That results in a cascade of events, because obviously your body would want it to prevent you from bleeding or your blood running out. So the clotting cascade activates where the platelets, which are small, round, little ball-structured cellular entities without a nucleus, will flow by the wound area. They will react to collagen as a stimulus or a molecule that triggers them. The collagen will bind to the platelets. The platelets will hyperactivate and start plugging the area. Next thing that will happen with the collagen, platelets released, will release all sorts of inflammatory or molecules triggering coagulation. The soluble clotting protein fibrinogen will, in the vicinity of this wound, will change from a soluble molecule in a healthy individual to an insoluble net via the clotting cascade, and that will result in the cut to be plugged. Now, if you imagine that if you are a person struggling with cardiovascular disease, that there are plaques inside your vasculature, the same type of concept can happen inside your vasculature, where a piece of plaque, cholesterol plaque, might be ripped off, collagen must be exposed, platelets rush to the area, soluble fibrinogen turns into fibrin networks, and that will cause a plug. And sometimes you might find that pieces of this clot might jump loose and progress to cause a heart attack or a stroke or something like that, deep vein thrombosis. Now, if we consider that as the general knowledge of what happens during clotting in a healthy individual, or perhaps where there's plaque or damage to the vessel, one could imagine that the soluble fibrinogen molecule that's in circulation might be quite activatable if there's anything in its vicinity that might cause damage. So what might cause damage? In circulation, we might have, when we've got diabetes, too much glucose. Cardiovascular disease, we might have too much other type of molecules that is related to cholesterol, and inflammatory molecules that are in circulation. When that happens, when inflammatory molecules are in circulation, these molecules spontaneously trigger endothelial cells by binding to the endothelial cell membrane to trigger damage to the endothelial cells. They may bind to platelets to spontaneously hyperactivate the platelets without them being triggered by an event like a cut, collagen exposure. And in the same way, in 2014, 2016, our research group, together with my long-standing collaborator, Professor Douglas Kell from the University of Liverpool, found out that in the presence of inflammatory molecules, also those coming from bacteria, for example, lipopolysaccharides, LPSs, might bind to the protein, the soluble protein fibrinogen, and it may change its structure. And we discovered that this change in structure causes the fibrinogen protein to become amyloid in nature. So this is not to be confused with amyloid, beta amyloid, that you will find in the brains of Alzheimer's individuals, or people with Parkinson's might have amyloid in the form of alpha-synuclein. So we're not talking about that type. Any protein changes might result in an amyloid structural change, and we were the first to discover that fibrinogen changes. Now, if we think about if you are very sick and you've got deep vein thrombosis, or you've got a clot in the lung embolism, clinicians would typically say, let's check for a marker. And one of the markers that they have to their availability is D-dimer. So you would expect, if you've got active clotting pathology in the form of a clot in the lung, you would expect a D-dimer to shoot up to tell the clinician there's something wrong with the individual. Now, unfortunately, with COVID and long COVID, the structure of these misfolded protein areas, the soluble fibrinogen into insoluble, that we coined the term microclots, is a total different structure to what we typically know as clotting pathology, where D-dimer would have an effect. Microclots consist of structurally different protein packaging. So they also act as little dustbins, where they roll on over damaged vasculature or endothelial layers, and we think they just collect everything that comes past them, and they don't break down as you would, because they have got this more complex amyloid structure. So you would expect in a typical setting without COVID and long COVID that microclots would perhaps break down and cause D-dimer levels to rise. But in acute COVID and long COVID, this doesn't happen, because these microclots are fibrinolytic resistant. So D-dimer is in fact not a good marker for someone with acute COVID. Perhaps still in acute COVID settings, it might still be in the acute phase, but definitely not in long COVID, because the clots that's supposed to break down, that would give the marker presence in the circulation, and in the form of D-dimer is not taking place, and the clinician would expect that the patient is not ill from clotting pathology, but in fact the patient might have microclots. And the reason why that might be the case, why are we missing it, can the question be? Well, one of the most easy explanations for it is nobody's looking for microclots because it was in a fraction in plasma where we found it that was supposed to be devoid of cells and devoid of soluble molecules that turned insoluble. So it's supposed to be devoid of any insoluble element. So we've been ignoring the possibility that there might be something in plasma. So I think the fraction of where we are looking for these microclots is where the question is, and how we could detect it. So with this long story, clotting is supposed to happen in a healthy individual. Sometimes it happens abnormally inside the blood vessels of individuals who have diseases like diabetes, rheumatoid arthritis, and sometimes these clots change their structure in such a way that they cause a clot that is not easily broken down. So it's fibrinolytic resistant.
Thank you so much for that very thorough insight. And I want to get into the different ways that symptoms can manifest that might make you wonder, is this microclotting? Or I guess what for a provider, is a symptom-based approach helpful, or what can they do to identify that microclotting is present? Or I guess what would be your advice on how to use this knowledge and inform a treatment strategy for someone with a post-acute infection syndrome?
So before we could talk about how it could be used to inform treatment or diagnosis, one must perhaps also just keep in mind that what are the roles of microclots? What are the roles of platelet that's hyperactivated, and possibly together with it, widespread or systemic endotheliitis? So one of the first questions to answer is, do we think that microclots are the cause of long COVID? And the answer is no, it's not the cause of long COVID. Do we think that it is a result of some pathology that's happening in the body? And the answer is yes. What might this pathology be that's happening in the background? The causes might be viral persistence. It might be RNA persistence. It might be widespread immune or autoimmune reactions. But the underlying concept of what is happening in our minds is that long COVID is a widespread vascular endotheliitis, which is driven by the presence of all sorts of inflammatory molecules in circulation, might be coming from viral persistence, if you like that type of angle to think where the constant spike, or this onslaught on their system comes from. So if we think about endothelial damage, and if we think about the fact that if you've got widespread endothelial damage, we could possibly explain many of the symptoms, if not all, of what is happening in long COVID. So just as an example, the vasculature is from the tip of your small toe to the crown of your head. There are vessels, blood vessels everywhere. Blood must flow to all of your organs, to your brain. The brain has got a vasculature protective layer, the blood-brain barrier, which is nothing more than, in easy terms, a vascular layer that's got protective layers in place to prevent things that's in the system to progress into the brain to cause damage. So if we think about that, and if we think that widespread vasculature is present everywhere, if there's damage to the vasculature, a few things cannot happen. If the vessel walls are damaged, then blood cannot go to and close and get in touch with the vasculature and give oxygen from the red blood cells into the organs. That can't happen sufficiently. CO2 can't be taken away sufficiently that you exhale. If you think about the presence of microclots, they might even temporarily, because they're quite big sometimes, temporarily block the small vessels so that oxygen can in fact not reach the vascular beds where it's needed in the smallest of capillaries. So if you think about that, and if you think about diagnosis and treatment, one must, I think, understand the disease and how it affects everything, and perhaps one of the focus should start with the vasculature. So that said, how do you measure it? How would a doctor go about now to measure it? Unfortunately, there are only a few things to be done to measure endothelial damage. There are a few instruments like an endopat, which is, it's like a cuff, and you see how responsive the endothelial layers are once you've, just precluded have a cuff around the vessel to press it tight. There's things like that. There's simple things like a capillaroscope where you could look at the nail fold to see how the vasculature looks like. If it's a light pinkish area, you know that the vasculature is compromised. There are a few blood markers that you could test for. I was talking about platelets. You could look at platelet hyperactivation markers, PAC1, CD62PE, those type of markers, platelet factor 4, which is indicative of a platelet being activated. Then you can look for endothelial damage markers like VEGF, all the various E-selectins, PCAM, ECAM, those type of molecules that are readily available in facilities, would usually does complex panels. So a clinician can ask for that to give an idea of what is, or to get an idea of what is happening with the molecular environment of the individual. Currently, the only clear diagnostic is probably a diagnosis of exclusion. You see what the symptoms are, you exclude that it's not this or that disease, and the clinicians do a wonderful job, some of them, to try to figure out exactly what is wrong with the patient. And then if they are in tune with the latest research, they would know. You could do a D-dimer, but it probably will not tell you much. So the idea is to, and that's what we are working very hard together with a lot of researchers, also the Petrino Lab, Amy Proel from Polybio Research Foundation, Kiku Iwasaki from Yale, of the Wust Lab from Europe, a lot of individuals that we are really working hard to try to establish what other possible markers there are, novel markers. And we think the microclot marker is one of these markers to indicate something is wrong. Because if you see microclot presence and you see platelet hyperactivation and you see some of these endothelial markers dysregulated, the logical explanation for it is that you've got widespread vascular damage. If you fix that with treatment regimes, perhaps not all patients might react the same. Perhaps you might have an effect on healing the vasculature and restoring oxygen and blood flow. That said, we must be very careful to say that a one treatment regime fits all. We must be very careful to use the word cure. Are we cured when we take something? We are very, very far from that. We need a concerted effort for trials. We need further testing. We need validation. We need FDA approval for the laboratory test that we developed. Am I confident that we will get it done? Yes, I am. Am I confident that it will take time and lots of money? Yes, which is sad.
I agree. It is sad. It often leaves the patient in a place of doubt and, I guess, frustration. What treatments, I guess, it kind of depends on where patients are located, what medicine they have available to approach things if they suspect that they have microclotting. So I guess, are there things that, like, even alternative medicine, or even supplements, or what are some things that doctors might hear from patients if they've done their own research and they're coming in and saying, I think that this will help me? Um, have you seen that?
So I'm just a disclaimer here. I'm not a clinician, so I am not really qualified to talk about treatment regimes. However, that said, I've been working with a few clinicians, not only in South Africa, but in Europe and also in the US, where and we are all involved in discussions on what to do and what mechanisms to follow. And some of these clinicians that I work with have been using anticoagulation therapy with great success. So basically it removes or blocks the clots from forming and it ensures that it breaks down sufficiently and blocking the platelet hyperactivation, and that gives time for the endothelial layers to heal. Now, that said, many researchers and clinicians will go, oh my goodness, no, bleeding, people going to die from bleeding. And yes, I do recognize that, and I'm not a clinician, so I can't say much about that. So we need clinical trials for that. But the bottom line is, as we understand it, those type of therapies, when microclots are present, and then obviously you need to confirm that they are present, so therefore we need diagnostics. If those are present, then taking such medication would remove the clots from the individual and just normalize the clotting pathology, therefore returning the individual to normal clotting propensity. And therefore we haven't been seeing people with brain bleeds or gastro bleeds in large quantities. Obviously there might be some that react, and therefore we need trials. But then on another avenue, there have been many patients that have been suggesting for years now already that enzymes, that is over-the-counter products like nattokinase and serrapeptase. Nattokinase comes from the natto health products that Japanese eat, and serrapeptase is another type of enzyme from silkworms that actually help the silkworm to get out of his cocoon when he wants to move on to a better life, so to say. And these enzymes are over-the-counter safe enzymes. Some people might have some reactions against it. And I have personally seen that it can reduce clot load specifically significantly, and with a reduction in symptoms. I've seen that in patients, and it's been noted by some individuals. Interestingly, myself and Professor Douglas Kell and his wonderful postdoc Justine Quickseef in the Liverpool lab, they've been doing the work in their lab, have been looking at a nattokinase molecule that they formulated, a purified molecule that they formulated in the Liverpool Institute, the gene mill. So the purified nattokinase molecule as well as fibrinogen, and they added that all together with molecule LPS from bacteria that causes the clots to form more significantly. And they could in fact show, and this paper is currently under review, that nattokinase in a lab setting can digest or break down clot caused by an inflammatory molecule that changes the protein structure, the fibrinogen molecule structure. So these type of experiments are really very important to see what happens in the lab. But then once again, it would be wonderful to test these products in a clinical trial. Of course, I think my dream team combination of molecules to test in a trial would be a combination of disprin or aspirin to calm down platelets, nattokinase, so that you don't use a commercial molecule for that a clinician would give for breakdown or prevention of clot formation so that you try to not have a bleeding risk. So not have Western medicine clot busting or clot preventing medications, rather replace that with natto and then perhaps something like Paxlovid or some other antiviral. A combination of antiviral, platelet calming drugs and nattokinase, I think, would be my first go-to dream team combo for a trial.
Thank you for sharing that. And so when you say relief of symptoms, what is the spectrum of symptoms that someone could experience that could result from microclotting?
I think every one of the hundreds of symptoms
Wow.
that have been reported by long COVID patients, anything from the brain fog, you could relate that to the endothelial layers that are compromised, and somehow microclotting and platelets might play a role in the damage of the endothelial layers, causing inflammatory molecules to enter the brain and causing havoc in the brain. The forgetfulness, the anxiety symptoms might be related to that. If you think about the muscle, compromised muscle, the post-exertional malaise that many people have complained about, the Wust group, Rob Wust is the leader of the study group in the Netherlands, have done a fantastic paper end of last year in Nature Communications, where they actually used our methods to track down where microclots might be in biopsies from individuals with long COVID, that they put through a exercise regime. So before exercise, during and after, and they looked at if there's microclots or where they are. And they actually found microclots with using our fluorescent marker inside the muscle area in those individuals, where in controls you would not have that. So why would we, once again, microclots is the cause of the symptom? I think no, it's probably, yes, well, I suppose depending on how you see it, it's probably because of the damaged endothelial layers that are more permeable, and these microclots that then just can wriggle itself into organ systems or muscle. If you can think it can happen to muscle, there's a good possibility that it might happen to the liver, to the kidneys. We have seen many individuals complaining of amyloidosis in kidneys or amyloid protein changes in kidneys. Skin changes, we have noted. The skin is obviously one of the last places that the body would want to worry about if that you are short in oxygen supply. So the body would rather give it to the heart, oxygen to the heart or to the brain. So skin is probably neglected by the blood flow, and because the individual body would want to preserve the more important organs. So if one thinks about that, it just makes sense that any of the numerous symptoms that patients complain about can be traced back somehow to damaged endothelial layers, because of and due to the presence of the spike protein, microclot formation, platelet hyperactivation, and a continuous process where these inflammatory molecules just don't get released or removed or from the body, and it's a perpetuating process. And unfortunately, it's like a roller coaster. If it starts off, you need to stop the roller coaster of progression into more severe symptoms. And if you just think how very important oxygenation to the brain, to the heart, to the muscle is, then one could explain many of the symptoms, if not all, by a damaged vasculature.
Wow. I have a question about inflammation. So is it worthwhile to treat the inflammation if that is what is driving the microclotting, or is it sort of a feedback loop where the microclotting causes inflammation and inflammation causes more microclotting? If we cut out some of this extra inflammation, would that alleviate some symptoms, or is it really the microclotting that should be addressed?
So perhaps to answer your question, one must first just step back again. What is inflammation in circulation, and what happens in the blood vessels? So if you've got inflammation, now just take COVID and long COVID and put it on a chair next to us. So we just talk about inflammation. Before acute COVID and long COVID and all of those viral diseases, if we not think about that, if we just think about inflammation, all inflammatory diseases have numerous presence of circulating inflammatory molecules. So in the case of diabetes, a lot of molecules, glucose. In the case of specific diseases that one can think about, there might be different suites of inflammatory molecules raised in specific diseases. If there are inflammatory molecules in circulation, they will find a receptor to bind to. That's a fact. It's a lock and key. Inflammatory molecules will find the receptor, bind to it, activate platelets. That's a given. We know that from years ago. Platelets are hyperactivated in inflammatory diseases. We know that these molecules will find the receptor on the endothelial layers and will bind to it and cause endothelial damage. We now know from work that we have done that obviously soluble fibrinogen do not have receptors. It's not a cell, so doesn't have receptors, but it's a protein. So we do know that inflammatory molecules might have a direct protein-protein interaction to the fibrinogen molecule, attach to it, change it into this insoluble amyloid fibrin structure or clot or microclot. So if we take that, if we have that in mind, and we step back to acute COVID, where we've got a massive surge of inflammatory molecules and spike protein to the mix, which also, by the way, are known to bind to receptors on platelets, on endothelial cells, and also cause clotting pathology by direct protein-protein interaction with the fibrinogen. We showed that in published papers. And others have shown, in fact, that the spike protein itself is an amyloidogenic protein that can cause other proteins to change into amyloid structure. If we take that into consideration, we'll start to understand that, yes, inflammation is a major issue in acute COVID and long COVID. Autoantibody activation is a major issue in these diseases. So what are the triggers? Some people, like me included, Doug Kell, Amy Prohl, many individuals working in this environment think that there might be a viral persistence behind it, spewing out spike protein. Even low levels can cause this inflammation. So yes, treating the inflammation is always a good idea. But the issue is, if we don't resolve the cause of the inflammation, in some individuals, treating the inflammation would be a chronic endeavor to treat inflammation. Perhaps in some individuals it will be fine, and the endothelial layers are healthy enough to have the resilience to not be affected so much. So the question is, yes, inflammation is important, but unfortunately, we have seen that in long COVID, microclots are fibrinolytic resistant or resistant to clot breakdown. So if those are in circulation, then as I mentioned, they act as little dustbins perhaps that roll over the endothelial layers and catch hold of everything and catch hold of inflammatory molecules. If you think that they've got a little ball of content with inflammatory molecules protruding out of them, that can again activate by interactions with receptors on platelets, on endothelial cells. So it's a complex process that we need to start with thinking about treatment regimes in a different way, I think. Yes, we need to treat inflammation, but we need also to look at the endothelial layers to heal it, to get oxygen to the cells. And we also need to think about is there a possibility for RNA persistence? Is there a possibility for viral persistence? We've seen some wonderful papers coming out from various groups that suggest there is. But if we don't get rid of those processes, we might always have spike protein somewhere in the mix. And I think that is where inflammation is critical.
Very interesting. Wow. I've learned so much. Thank you. So I guess I know you're not a practitioner, but if you could put yourself in the shoes of a practitioner, how do you think, what is the best way to approach something so complex, and where you may not be able to answer every question?
That is a difficult question. I've had it from many patients and clinicians and researchers. And I always say to them, I would suggest to approach it like the very cliche comment, how do you eat elephant? Bit by bit.
Yes.
So I think the most important thing, number one, is to listen to your patient. Listen to the patient. They've got the symptoms. And because the symptoms are so diverse, 10 patients in your room on a Monday morning might all have long COVID, and all will have a different combination of these symptoms. So don't treat it as a one fit process. This is the disease, this is what you treat, and there you go, the patient will go away. It's not like we see diabetes. If a patient's got a diabetes diagnosis, the clinician knows, I must give this, I do this, and the patient will go away and be better. And if the person eats healthy, lose weight, do whatever I tell them, they might even get better and not be on the meds. Long COVID isn't that. Not yet. And why is that? Because we don't have proper diagnosis for a wide range of novel tests. So long COVID is not a disease with a set regime that one should use, with a checklist that a clinician can check down. This is the symptoms. These are the diagnostics. These are what you need to give the patient. And then if the patient recovers, then you know your regime works, or if your patient feels better. Long COVID is not that. Long COVID is a new disease. We need new diagnostics. We need to rethink what the symptoms are and how we're going to treat it. So the best thing that I can recommend for a clinician is listen to your patient. Look at the symptoms, look at the patient in front of you, and perhaps we are returning to a word that was a hype word a few years ago, personalized medicine. And many clinicians will roll their eyes, and the NHS and the NIH would say, okay, but the thing is we can't do personalized medicine for every patient coming past a practice, because long COVID patients are so diverse and need so much more specialized care possibilities. Hopefully, in 10, 15 years from now, we would look back at this podcast and we might say to each other, now 10, 15 years along the line, we do have a diagnosis. We do have a clipboard. We now can tick this, and this, and give the patient this, and that. We don't have that luxury now. Ask for a batch of tests that might differ from patient to patient. Perhaps you need to ask for endothelial markers. Perhaps in the second person, you don't need to ask for that. But use your medical training knowledge to the benefit of the patient. Don't act as if they are a textbook with a specific list of what is supposed to be done. That's not working.
Thank you so much for offering that perspective. And I appreciate you saying all of this. And it's very consistent with what we're hearing from other scientists, from healthcare practitioners, physical therapists, doctors, specialists. Across the board, the message is the same. listen to the patients, take time to understand what their history is, and understanding that each patient does bring a unique situation to the forefront. And it's important to not dismiss their experience and just understand it as it's unique. And that understanding is necessary to your approach in how you treat post-acute infection syndromes. And so I'm sure it'll be really affirming for the students to see how universal this advice has been throughout every episode of the podcast. I mean, we didn't plan that for everyone to say the same thing, but it's true. It's very true. And also very inspiring. I think that, knowing that there are people behind this, whether they're researching or, doing more of an applied treatment approach, people care, right? People care about the patients. I would, before we close, I just would love to learn about how you got into this work and what really inspired you to do this research.
So I've been working in the coagulation environment probably since 2004, when I started looking at interesting ways to study coagulation. And I think the reason why I have been so lucky to find all of these discoveries, microclots and all of the methods and discovery medicine, which is my passion, is that I don't follow textbooks. I look at what I have in front of me. And I think the most important thing is that discoveries won't happen if you don't think out of the box. And I think I'm quite good in recognizing new things, not opening myself to new things, and not wanting to see something that I have a hypothesis should be there. And I think we have been very successful in doing that, and just looking at what you have in front of you. And I've been doing it since 2004. Time is always a good thing. It just opened possibilities for us to be open-minded, and luck is a good thing.
Yes, and I can't imagine how rewarding it must feel, for your research to be so heavily cited and understood and appreciated, and serve as a foundation for this very important issue that is now affecting millions and millions and millions of people. I mean, countless people. So congratulations, really congratulations on your work, and thank you for what you do and the role that you serve in the scientific community and the medical community. We appreciate you, and it's really been a pleasure to have the opportunity to speak with you today. Yes, and so is there anything that we haven't spoken about that you would like to make sure our medical students know before we say goodbye?
No, I think we covered everything. Thank you so much, Raven. It's been a pleasure to speak to you.
Of course, yes. Likewise, the pleasure is all mine. Well, with that, I'd like to conclude our episode of the Raise the Line podcast. Looking forward to speaking with you on the next episode. Bye, everyone.